Greetings everyone. I am presenting my video on a new innovation that is OmniFlow, a novel, small and effective drainage device for complicated open-angle glaucoma. OmniFlow is a unique sutureless, sure shot shunt and the best glaucoma drainage device to drain aqueous humor from anterior chamber to retrobulbar space. A micro-wall tube pressure regulator is fitted inside a soft flexible silicone tube which controls the outflow of the aqueous humor, which will prevent hypotonic and maintain IOP between 10 and teen 24/7 with no to minimum need of anti-glaucoma medications. This is how OmniFlow tube looks. Minimum IOP back pressure is maintained by Bernoulli's principle, which essentially means that in a narrowing tunnel the primary pressure P1 is proportionately resisted by secondary pressure P2. Minimum IOP of 10 mm of Hg is also maintained by another principle, that is anti or reverse capillary action, which means that if capillary is hydrophilic, it will attract and suck the water, but when the capillary is hydrophobic, it will repel the water back. Hydrophobic capillary wall tube made of Teflon will resist the aqueous humor passage, maintaining a minimum back pressure of 10 mm of mercury. Retrobulbar space behind the equator is almost free from myofibroblast. Therefore, it is virtually free from fibrosis even without mitomycin C. Retrobulbar space can easily drain up to 500 microliters per minute without any engorgement, proptosis or chemosis. Aqueous humor production and outflow discharge rate is only 3 microliter per minute. OmniFlow supplied tube length is 50 mm and needed length is 30 to 40 mm. Axial length plus 5 mm is the ideal and enough length to reach retrobulbar space without touching the optic nerve head, without any folding, kinking or overcrowding the retrobulbar space. Let's see few surgical videos of OmniFlow tube implant. So it is done under peribulbar or subtenon block. OmniFlow tube is anchored in sclera without any suture, and as seen in this video of failed trabeculectomy, the tube is so firmly secured no matter how much we nudge, the tube will not budge. The tube is primed with 27 gauge hydrocannula and BSS solution, and the discharge of the aqueous humor is proportionate to the pressure which we are creating in the syringe. With low pressure, there will be no drops falling. With high pressure, there will be jet streams of aqueous coming out, and with medium pressure, only drops will be coming out. After putting a L-shaped cut in the conjunctiva and after little blunt dissection, insert a wire vectus to reach the retrobulbar space, which is very easy, and up to 40 mm of wire vectus can be inserted with ease, and it creates a smooth tract. Minimum and gentle bipolar cautery is done. After this, at 45 degrees and 5 to 7 mm away from the limbus, a scleral tunnel is made with 23 gauge angled MVR blade. This tunnel is properly lubricated with 2% HPMC OVD solution. The beveled end of OmniFlow is now inserted in and passed through the scleral tunnel. 3/4 of the length of the OmniFlow tube is pulled out, and the wall distal end of the tube is inserted into the retrobulbar space, which goes into the retrobulbar space quite smoothly and easily without any resistance. The excess length of the tube is pulled back and pushed back into the retrobulbar space. Now, a second scleral tunnel is made, which is radial or perpendicular to the limbus up to 2 to 2.5 mm from behind the limbus, which is then gently entered into the anterior chamber, bisecting the angle of the anterior chamber and the iris. Now, the beveled end of the OmniFlow tube is inserted into the anterior chamber via the second scleral tunnel. Care must be taken that only the beveled 1.5 to 2 mm end goes inside. Then the excess band of tube is pulled back and slowly pushed back into the retrobulbar space. After this, the firm anchoring of the tube is confirmed by vigorous pull, push and side movements. In the end, fibrin glue is put over the sclera and conjunctival flap is reposited and sealed. Entire surgery is of 10 minutes with no sutures. There is no induced astigmatism, so it can be implanted along with toric and multifocal IOLs. In this video, you can notice the decent anterior chamber depth. When the tube is in focus, IOL is out of focus, and when IOL is in focus, the tube is out of focus. So, there is no hypotonic choroidal effusions or any hypotonic maculopathy. This is an interesting case of traumatic subluxation of crystalline lens with angle recession glaucoma and dilated pupil. The tube gets blocked by incarceration of prolapsed vitreous strands. Vitrectomy relieved the tubal blockage. The intraocular pressure came down, and so the mydriatic pupil also became smaller. Post-RD surgery, silicone oil-induced glaucomas are extremely difficult to treat and are really intractable because of total blockage of collector channels by emulsified silicone spherules embedment. Omniflow drainage device can cure such conditions even after 2, 3 or 4 failed trabeculectomy. This is a case of double omniflow. IOP was around 100 in a one-eyed patient who had undergone multiple RD surgeries with repeated silicone oil injections with multiple failed trabeculectomy. Omniflow is the surgical management of choice for neovascular rubeotic glaucoma. In this one-eyed patient of Sturge-Weber syndrome, after 4 failed trabeculectomy, Omniflow saved the only working eye. In 23 patients, the IOP came down from 30 to 70 mm of Hg to 10 to 15 mm of Hg immediately after surgery. 18 patients maintained this level of IOP without any medications for a year. 4 patients required dorzolamide plus timolol combination eye drops, and 1 patient required 1 more tube placement. 2 patients of no PL gained vision of finger counting 1 meter to 3 meter after tube placement. This is due to constant IOP between 10 to 12 mm of Hg 24/7 without any night surge. The nerve fibers which have recently gone dysfunctional and are semi-dead can resurrect and are revived. So, in conclusion, Omniflow will revolutionize the management of all types of primary or secondary intractable open-angle glaucoma, neovascular glaucoma, silicone oil-induced angle recession, posterior embryotoxin, and glaucoma in Sturge-Weber syndrome in a most cost-effective manner. These are my acknowledgements. Thank you.